Good afternoon. And today we have a very special guest. Good afternoon, Nicole.
Hello, Dr. Sokolina. Thanks for having me.
And thank you very much to our audience. If you have trouble sleeping or sleep next to snoring partner, especially if your child also have a trouble sleeping, this program is going to be for you because we're going to talk about myofunctional habits and speech problems, which might be related to bad sleep. And if you're a medical professional who, just like us, trying to put all the pieces of puzzle together to find the best treatment options for their patients, this program is going to be for you. We're going to talk about root causes of a lot of problems. And I would like to introduce Nicole. Nicole, just like me, have a podcast, and she's going to talk about her program, and she interviewing a lot of wonderful professionals and trying to find, root causes of a disease. But also she is owner and a founder of speech and language pathology practice with myofunctional therapy component, I would say. So she treats both speech and myofunctional problems. And she is in the process of publishing children's book, and she's going to tell us all secret about the book. And also she is a well-known speaker, and she's very active in our community to bring those knowledge to young professionals, to dental professionals, and medical professionals. But for me, Nicole played a very special role in the Mewing conference where I just presented. Nicole interviewed Dr. Mew, and I really tried to get him on my program for a long time. But when I saw this interview, I reached out to him again. And before, he used to just refuse it. I guess it was the wrong time. But after Nicole interviewed him, he was very happy to be on my channel, and I interviewed him, and then I got invited to that great Mewing event, and I met a lot of wonderful professionals from around the world. And now I'm going to learn about what they do with the sleep apnea problem in Romania or in Greece or maybe even in the United Kingdom. So it was Nicole who made it happen, in a subconscious way with her podcast, but I give all credits to Nicole, and I, forever, eternally thankful. So my first questions to you, and it's very unique for speech and language pathologists to also have myofunctional therapy training. So tell me about how do you see what many speech issues also have myofunctional problems, and can you explain how those two areas are connected? In our ecosystem, a lot of people look at that like a competition in a way, but tell me how you practice in this area for so long. What do you see?
Yes. Well, thank you so much for the introduction and thanking me for that connection I didn't even know I had until we talked today about that. So it's just so wonderful. So thank you. So we're talking about speech problems, and I'll focus specifically on speech articulation, so how we produce speech sounds, and the relationship to myofunctional disorders. Because I got started in the specialty area of myofunctional therapy for that reason. Little did I know that my whole family has sleep and airway issues. So it was not even that. But I got started when I worked in a school district for 7 years. And in my master's program as a speech pathologist, we didn't have training in myofunctional therapy. So it's not necessarily a standard of training in speech pathology programs, although the work that we do as speech pathologists does overlap with patients who have myofunctional disorders. So when you refer someone for myofunctional therapy, just make sure the speech therapist has advanced training in myofunctional therapy. Okay, so that's one thing. So that's important to know. But what happened was I worked in a school district, elementary, preschool through elementary through 6th grade, and I worked with a lot of children with speech articulation issues. So a lisp, so they might say bus, like a frontal lisp, A lateral lisp, where speech might sound slushy. So bus might sound like bush, bush, where air is coming out the sides of the tongue. Kids who had difficulty with the R sound, they might say rabbit like wabbit. And we would treat a lot of these issues sort of through like a drill and kill approach, where we drill the sound out, isolation, words, phrases, sentences. And we might do some strengthening exercises of the mouth and tongue movements. But there was no recognition that most speech articulation issues are actually just a symptom of an underlying orofacial myofunctional disorder. And if you don't treat that root cause, the speech issue may never fully resolve or may take years to resolve. So I would have these students being pulled from class to come to see me for speech issues, and they'd miss 30 minutes, an hour of class a week for years. And the speech issue was getting better, but it wasn't always carrying over to conversation. So when they weren't consciously thinking about it, that speech problem would just come back, or it's taking a really long time to resolve. And I'm looking at these kids' faces, and my curiosity alarm is going off saying, wait a second, why does that kid look like he has a large tongue, or like just kind of like this floppy tongue? Why does that kid have baggy eyes? Why is that kid's mouth always open, right? This was not something that was standard of education when I did my training, right? That these are red flags. So I'm looking at this, and there was one myofunctional therapist in my area in San Diego who that was what she did, was myofunctional therapy. And I learned about that, and I started taking courses. So in 2008, I took a course through the IAOM with Joy Muller, Leisha Pasquet, Barbara Green, and then I took another course, and that's where everything just snowballed into this rabbit hole of, wow, 81% of children with speech articulation issues, or a high percentage, have underlying myofunctional disorders and or orthodontic comorbidities. And that is the missing link. So this speech issue we see is oftentimes just a symptom of this other problem that needs to be addressed. And so I view it as the saying, posture is the foundation of function. Every movement that our articulators make are dependent on the resting position of our articulators and where they will go back in that resting position. So if we are sitting with our tongue low, forward in our mouth breathing or not, just low tongue posture, why would we ever expect our S sounds to be produced up behind the top teeth in the correct position when the tongue's not resting that way? So we have to correct resting posture in order to help with speech articulation, right? However, just if we correct the myofunctional issue, the speech issue will not resolve. Usually the speech issue needs to be directly addressed in speech therapy as well, because those underlying linguistic patterns and neurological patterns are also ingrained. So we must treat the OMD, the myofunctional disorder, and the speech issue directly, not leaving either one of those out. So it's funny you asked me that question, because for some reason a few days ago, I guess I was bored visiting in-laws in Oregon. My husband's like, I'm going to play pickleball for 10 hours today while I'm just sitting there. I'm like, okay, what am I going to do? And I wrote an article that ended up being 20 pages. So I need to figure out where this is going to get published, and I'm going to shorten it. It's probably going to go into Dental Sleep Practice magazine.
Great magazine. We all love it.
Yeah, I'm going to have to cut it down to 1,500 words to get in there. I'm going to try to get it into ASHA, our American Speech Language Hearing Association journal or magazine. But the title is called Recognizing Speech Articulation Deficits as a Symptom of Orofacial Myofunctional Disorders. Clinical Insights for Speech Language Pathologists, Dental, Orthodontic, and Medical Specialists. And the little subtitle I'm going to read to you. Speech articulation issues may serve as an overlooked marker of orofacial myofunctional disorders, underscoring the need for collaboration across dental, orthodontic, and speech pathology disciplines. And it's not just articulation, but even our children who are in speech therapy for learning disabilities, cognitive issues, many times there are other underlying myofunctional disorders triggering poor breathing and poor sleep, and the brain and body can't function well. And I had this one student that always comes to my mind. I worked with him for years from preschool through elementary, and he had every speech pathology problem in every domain. He had a hoarse voice. He had language issues, so language processing, expressive language issues, so his sentence structure was off and was delayed. He had he had all the large tonsils, but I didn't realize that until after I learned about what I know now. But he had just ADHD, all these other issues. His mom would have to bring him to speech therapy privately when I worked privately, no longer in the schools, but private practice, with a soda and a candy bar in his hand, because that was all she could do to motivate him to get him to come, which I understand, right? Our kids are just like getting by when they have these issues. Little did I know that this child had a major myofunctional disorder because I didn't know about it at the time. He had an anterior open bite, low forward tongue posture, tongue tie, which I didn't realize all this, large tonsils, hoarse voice because he had reflux, because when we have sleep disordered breathing, we're sucking up that stomach acid, burning the tonsils. So every underlying domain, he had memory issues, every underlying domain of the problems I was treating was rooted in orofacial myofunctional disorder, triggering poor sleep quality. And until we recognize that, we're really doing a disservice to our children, students, patients, pulling them from class. Parents are paying money for private practice, taking their kids to private therapy, burning our kids out if we're not really getting to the root cause of a lot of these problems. So that is my soapbox.
This is a beautiful thing. I would like to ask you, I'm so curious about the book you're writing for kids. What can you talk about that? What idea you're trying to bring in the book? What do you want to change with your book?
So I started thinking about this in 2019. I was interested in doing some program for preschools, kindergartens, to help children learn good oral rest posture, good whole body posture, as some fun program to get them, nose breathing and thinking about these things. So kind of developing something that could be used in schools. And then COVID hit and nobody was in school anymore. And I already had character names picked out, and I even had little sketches and all this. And then I just kind of stopped. I just let it just go away. And then recently, a few years ago, I'm like, I'm still inspired to do this. Funny, because I think I was visiting my in-laws in Oregon. Not that they're boring, but it's very peaceful, and staying, out in nature, thinking like, I'm inspired right now. And I just started writing it. So it's kind of a Dr. Seuss rhyming sort of book, and kind of fun, engaging for that preschool, kindergarten, first, maybe second grade age level, where I envision a teacher might be reading this to a group of students, but it could also be used in a therapeutic setting with speech therapy, myofunctional therapy, dental office, to help teach children how their mouth should rest, how they should be breathing, what their body posture should be like. But it's from the viewpoint of a superhero. So the title is The Adventures of Captain Airway and Mr. Mighty Mouth. So we have all these fun superheroes, and I would like for it to be multiple parts. So after this introductory book going over everything, then we're going to have different characters that are like bad characters that cause nasal congestion and things like that. So this first book goes over good posture, good breathing, how in like a fun, whimsical way with these superheroes. So that's where I am. So we're almost at the end where the illustrator's just finishing up the illustrations.
Very nice. I'm looking forward to introduce my audience to your book, because I think if you start with the young generation, then people gonna grow up thinking, in those categories. So that's gonna be a big change. That's how you making this world change. So talking about change, I want you to talk about 3-system model for evaluating and treating the orofacial disorders. And can you please talk about this oromotor disorders, right? OMD.
OMG, orofacial myofunctional disorder.
Orofacial myofunctional disorder. It's such a difficult abbreviation for me. And I want to know what's the 3-system model and how can it help us to bring that to reality? Because you're actually connecting the dots, how we can make other practitioners to connect the dots.
Yeah, so my mentor taught me about this concept, and it's just stuck with me ever since, to make the whole diagnostic process of myofunctional disorders and the treatment more black and white. It's really not that hard. It's not that complicated. It's complex because there's multiple factors, but it's not always that complicated to see what's going on. So if that makes sense. So what she taught me is that there's 3 interacting systems in the human body when we're looking at myofunctional disorders. And we need to look at those 3 systems. So I kind of drew it as like almost like the Olympic, but only 3 circles, kind of overlapping, right? 3 overlapping systems. We have the myofunctional system, which is the medical system. I mean, which is the myofunctional, the muscular system. So myo means muscle, how those muscles function. And then we have the dental system, or you might call it the dental skeletal system or the craniofacial system. And then we have the medical system. I'll talk about what is in each of those systems. I'll quickly kind of review that. But what I want us to understand is those 3 areas or systems interact as a team. And any dysfunction or altered functional pattern in any one of those systems can affect the others, leading to problems in the oral cavity. So in the myofunctional system, we're going to look at how our tongue rests, how our lips rest, our dental freeway space between the jaws, how we chew, how we swallow. Do we have any oral habits? Okay, so that's the myofunctional system. And oral habits, noxious oral habits might be like finger sucking, thumb sucking, other finger sucking, biting habits, chewing habits, bottle use, pacifier use, things like that. Then in the dental skeletal system, we're going to look at the shape of the dental structures like the palate. Do we have a narrow palate? Well, that could be caused by low tongue posture. But once the palate's narrow, that can impact the tongue resting position, right? So we look at this interaction. We look at the maxillary and mandibular relationship. So if someone has a significant class 2 malocclusion where that lower jaw is so far back, that's going to affect lip closure, or it can affect lip closure because it's going to be hard potentially for the lips to remain closed. So we look at things like that. We look at tori. A tori on the palate could impact tongue's resting posture. Palatal appliances like rapid palate expander will impact how the tongue is resting in the palate. We're going to look at appliances like night guards can open that dental freeway space up and make that person open mouth breathe when they're sleeping, right? So there's all these different interactions that can occur when we look at the dental system, which we need to look at. And then the medical system is any medical factor that may influence how the muscles work. And this is really important to take into account our nasal patency. Can we breathe easily through the nose? And that is the first thing that needs to be investigated and addressed before anybody even begins treatment to rehabilitate the muscles of myofunctional therapy. If you cannot breathe through your nose due to a structural issue, that needs to be rehabilitated, the medical reason, before myofunctional therapy occurs. Now, the myofunctional therapy evaluation should definitely occur right away because we help diagnose those things and refer out to specialists. But when we're looking in the medical system, we might look at allergies, congestion, deviated septum, nasal polyps, nasal valve collapse, mucus in the mouth, or in the nose, things like that. We might also look at patients who have chronic illness, respiratory illness, which could cause mouth breathing. Are there large tonsils and adenoids? Is there tongue or lip tie? So those are all factors in the medical system. So all of those systems need to be evaluated, investigated, and treated to get full resolution of that myofunctional issue. So we need to look at all of those components. And once we resolve an issue in one of those domains, it doesn't mean another issue is not going to come up later, or that same issue might reoccur, like enlarged tonsils. After a patient gets their tonsils removed, or I shouldn't say enlarged tonsils, more like adenoid enlargement. Once the patient gets an adenoidectomy, it doesn't mean in a few years they might grow back again. So we always need to be detectives in this evaluation and treatment process.
No, that's a beautiful systems. I love it. I would like, first of all, I want to invite my audience to check your podcast. That's a great way to gain a lot of knowledge, and under the very different light. I have a dental sleep medicine light. You have sleep and myofunctional light. So it's very educational. So thank you very much for that. And I invite my audience to check it out. And you can find information about Nicole underneath this interview. But I want to ask you about your journey with sleep apnea, or with your own, because I find it quite unique, starting with a sleep study, which I find very educational, and moving forward from that. Can you share your journey with us?
The journey never ends, doesn't it? Yeah, just because we know information doesn't mean we're relieved of the problems that come with this knowledge. We just can treat it better, quicker, more efficiently. But yeah, so my journey with my son, my first son, who had sleep apnea at a very young age, which I wasn't aware of at the time, almost 14 years ago. But my mentor, who was a myofunctional therapist, was able to help me identify that was the problem. And I really did not know why he was so hyperactive, ADHD. We know children who have poor sleep quality can become hyperactive in response to that poor sleep quality. I didn't know why he's running around the room like crazy when I take him to like the Mommy and Me, music classes. Why is he the only kid running in circles? Mouth breathing, snoring. Actually, a lot of these issues began at birth, if not prior. Looking back at baby photos, you could see his lower jaw was very retruded. He was born with tongue tie that wasn't very evident to anybody at the time because it was more posterior in nature. So it wasn't to the tip of the tongue. So that was missed. There were hundreds of issues, nursing issues. I nursed him till he was 18 months old. Still compensated through that process, but like his tongue he'd make clicking sounds because he was breaking the suction from the tongue tie. So he'd make clicking sounds, latch issues, milk came out of his nose. He would fall asleep nursing because he was working so hard. He would writhe his back in pain after breastfeeding because he was swallowing air, what we call orofacial induced reflux. When there's a tongue tie, the baby can swallow air because that tongue's not sealing off the oral cavity. And he was put on protein pump inhibitor medication for reflux at 1 month of age. So there were these ongoing issues, and he started snoring, all this stuff. So when he was 2 years, 11 months is when we had his tonsils and adenoids removed, tongue tie released, and started really going down the path of fixing those problems because nobody knew the cause or what was going on. Everybody told me these are just common issues that parents might have, that babies might have, and we were just treating symptoms. And even a pediatrician saw his tonsils that were graded 3+, so nearly touching, and said they're fine because they're not red or inflamed. So it just lots of like being misled, confused, and coming on my own journey, finding out that there were myofunctional problems, sleep problems, airway problems, that honestly research shows that there is brain damage. When that occurs at a young age, that causes changes in brain development. There is fMRI studies showing there's reduced gray matter in the brain. So that was kind of the start of this process. That's a long journey because then we have to correct all three systems. And like I said, the issues don't always go away. Things come back over time, in boys as they start growing. Even if you resolve the sleep apnea at a young age through tonsils and adenoid removal, palatal expansion, tongue tie release, and they're quote unquote cured, there's a high relapse rate around the time of puberty because the tongue enlarges, right? So we always need to be attentive to these issues that oftentimes are displayed in behavioral problems, daytime behavioral problems. Also nighttime issues we might see like snoring, gasping for air, restless sleep. So that happened with my son, and we did orthodontic treatments, myofunctional therapy, ENT treatments, ongoing, lots of different treatments. Also, I found out his adenoids grew back. So that was one thing that occurred. Then also I come to find he has a non-airway related sleep issue. He has periodic limb movement disorder, restless leg syndrome due to low iron, low ferritin. So there's all these things that can impact our sleep quality. And it's kind of like we got hit with everything, I feel like. So I've really learned so much by just being on my own journey with him. And then I found I have upper airway resistance syndrome. My husband has sleep disorder breathing as well. My other son as well. So it's a family affair. But yeah, for me, I got that figured out through specialized testing with Dr. Gerald Simmons in Texas at the Comprehensive Sleep Medicine Associates, who does the gold standard method of diagnosing upper airway resistance syndrome, which is it's called PES, pharyngeal esophageal manometry. So they put a catheter through the nose, down the throat. It's not as bad as it sounds. It's fine. I'm like a scaredy cat, and I was able to do it just fine multiple times. And it measures negative intrathoracic pressure. In other words, how hard are you working to breathe? How much negative pressure is in your airway? And what happens to your brain? As you work harder to breathe, does your brain arouse from its sleep cycle? And that is just complete obstructions, or patients with UARS aren't dropping in oxygen. Their brain is just arousing when there's slight increasing efforts to breathe. So they're just more sensitive, but having similar effects on the body. So that's how I got my diagnosis. So I went through my own orthodontic treatment plan as an adult, because my orthodontic treatment plan as a child involved headgear, retractive techniques. So there were signs when I was young.
You reverse.
Right. So then, so I had the MARPE and things like that as well. I was on a CPAP, that whole thing. So I really feel like a lot of my knowledge is from personal experience, and then also attending a lot of coursework.
Thank you very much for sharing your story. We appreciate, so much openness, and people who have upper airway resistance syndrome, after hearing your story, have a hope. So thank you very much for that, and we really appreciate, you sharing a lot of knowledge. And I invite people to listen to your podcast. Thank you.
Thank you. It's called Airway Answers with Nicole Goldfarb. Yeah. So YouTube channel is the best way, because it's good to see versus just going to the audio podcast. But yeah, thank you so much for letting people know.